our next speaker, Dr. Jayashree H K from India, to deliver her speech, please. Thank you.
Am I audible?
Yes, please.
Yeah. Is my screen visible?
We are just waiting. Yes, now it's visible. Thank you.
Yeah. Good evening, everyone. Myself, Dr. Jayashree. My topic for poster presentation is manifold chromosomal abnormality with TP53 mutation in a case of AML M2, a rare case report. Coming to the background, acute myeloid leukemia. Since I have a great interest in hematology, the reason for choosing this topic. Before coming to the topic per se, I would like to thank UCG platform for giving me this opportunity for my poster presentation. Acute myeloid leukemia is a tumor of hematopoietic progenitors caused by acquired oncogenic mutations that impede differentiation, leading to the accumulation of immature myeloid blast in the marrow. The replacement of marrow with blast produces marrow failure and complications related to marrow failure. Cytogenetics and flowcytometry are the valuable tools in the clinico-pathologic management of leukemias. Case report. A 55-year-old female, non-diabetic and hypertensive, already immunocompromised, presented with recurrent UTI with frequent candidal infection and cystitis. The routine hematological test revealed anemia, which was hemoglobin of 7 gram per dl, and with leukocytosis. Total leukocyte count was 22,800 and moderate thrombocytopenia. It was 50,000 of platelets. Peripheral smear examination showed increased number of blasts, 31%. She was referred to a dedicated hematology team for further workup. Bone marrow aspiration and biopsy was conducted. Cytogenetic and molecular genetic studies were also done. Flowcytometry using FACS analysis on bone marrow aspirate showed abnormal blast population of about 22.5%. This is a bone marrow aspirate picture showing blast with maturation and the arrow showing ore rods, which are acidophilic granules, which are present only in myeloblast and not in monocyte. These are differentiation features because to describe myeloblast, it have delicate nuclear chromatin, 2 to 4 nucleoli and more voluminous cytoplasm than lymphoblast. Here, presence of ore rods is the pathognomonic feature of AML M2. Following fluorescent label antibody markers were used against CD antigen. The antibody panel included were CD34, CD19, CD10, CD20, CD22, CD38, CD2, CD3, CD4, CD5, CD7, CD56, HLA-DR, CD13, CD14, CD15, CD33, CD64, CD117, which is the AML marker, CD123, and cytoplasmic myeloperoxidase. In the above mentioned antibody panel, CD34, HLA-DR, CD33, and cytoplasmic myeloperoxidase were moderate positive, which all these CD markers expresses myeloid lineage cells. And CD117 moderate to bright positive, which is an AML marker. CD38 and 13 were dim to moderate positive. For myeloid blast, a combination of CD34 and CD117 can be used to define immaturity of the blast. Myeloid lineage is suggested by expansion of antigens including CD13, CD15, CD33, and myeloperoxidase. Myeloperoxidase is an important marker to differentiate myeloid lineage and lymphoid lineage. Myeloperoxidase is only positive in myeloid lineage. Monocytic lineage is suggested by expression of antigen including CD4, CD14, and bright CD33 and 64. Cytogenetic analysis. Karyotype abnormalities and clinical features were linked with abnormal antigen expression characterized in AML. Our patient presented with complex karyotype. Complex it is called because there is damage in more than 3 subsets of chromosomes. 45, 46, XX, deletion of 5q21, deletion of 7q22, minus 12, addition of 8p22, and addition of 16q22. Cytogenetic analysis. Complex karyotype. As I said before, there is abnormality in more than 3 subpairs of chromosomes, it is complex or monosomal karyotype, which always conveys high risk and relapse. Deletion of 5q21 results in loss of tumor suppression by adenomatous polyposis coli gene. Deletion of 7q22 results in loss of CUX1 gene, which is a low frequency mutation gene. Mutation in CUX1 gene results in dysregulation of PI3 kinase pathway. This is a flowcytometry after the first relapse, which showed MRD of 0.6% of all viable nucleated cells. Here, the third image, the orange indicates erythroids, the red indicates blast, and the blue color indicates lymphocyte, and the green color indicates granulocytes. So in this figure, abnormal blast even showed dim to moderate CD45 with low to medium side scatter. Subset of blast show bright CD34 and CD117. CD13, CD33, and 15 and MPO are bright positive. Aberrant CD56 expression is noted. CD34 and 117 define immaturity. CD13, 15, 33 define myeloid lineage. CD4, 14, 33, and 64 define monocytic lineage. This is MPO positive. This is a dot plot of showing positive bright aberrant CD56. The later MRD after transplant showed abnormal blast events 1333, which downregulation with aberrant CD7 and CD56. Come to the result, the final diagnosis of AML M2 with complex karyotype and TP53 mutation. To call AML, the blast percentage, the maturing percentage of blast should be more than 10%. And presence of TP53, which is an unfavorable prognosis, and MRD will always be positive with increase in relapse and expected with complex karyotype. So here, if there are more than 10% of maturating myeloid cells, there will be always CD45 dim positive with low to medium scattering in a blast window. Refractory AML M2 with TP53 gene mutation is very rare and seen in only 10% of cases and leads to relapse even after effective cytotoxic chemotherapy with poor prognosis. Hypomethylating agents with BCL2 inhibitor were used, conditioned with triosulfan, fludarabine, and taken for allo-HCT. Predicting the prognosis, bone marrow transplantation can be considered over chemotherapy for better outcome in high-risk cases. Discussion. Flowcytometry is crucial for detection of leukemic blasts, blast lineage assignment, and identification of aberrant immunophenotypic features that allow distinction of abnormal blast population from normal progenitors. Leukemic blasts frequently show immunophenotypic deviation from the antigenic expression pattern seen on normal hematopoietic progenitors of similar lineage and maturation. This basic principle allows for the recognition of leukemic blast determination of the immunophenotype, and subsequent classification in AML. Molecular genetics. Most patients have multiple gene mutations and dynamic pattern of disease. This is a challenge to deal with. This patient presented with TP53, a tumor suppressor gene mutation located on 17p13.1. TP53 encodes for the guardian of the genome. Its frequency of mutation is up to 10% in de novo cases, more than 20% in therapy-related myeloid leukemias. In AML, there is strong mitogenic signaling, and the cell cycle inhibitor genes such as TP53 are frequently lost. TP53 gene mutation. Most patients have multiple gene mutations and dynamic pattern of disease. Treatment protocol. Patient was given hypermethylating agent, that is 100 mg of azacitidine initially. Blast percentage was significantly dropped, but patient relapsed after 3 cycles. Even with the addition of BCL2 inhibitor, that is venetoclax, blast count increased to 33 and later increased to 50%. High-dose chemotherapy, which is HiDAC with cytarabine, failed to achieve the goal of remission. The last option considered was resort salvage therapy with fludarabine, triosulfan, and conditioning regimen for bone marrow transplant. After the transplant, the donor mapping was done and the recipient mapping was done, comparing the both post-transplant on day 21 of marrow showed 100% of donor stem cells. Post-engraftment blood workup showed 99.17% donor DNA and 0.83% recipient DNA on 50th day of transplant. Conclusion. Cytogenetics and flowcytometry are the paramount importance of clinician in tailoring and prognostication of disease treatment protocol. Unlike many other human cancers, a vast majority of acute myeloid leukemias display no genomic TP53 alterations, but in AML associated with TP53 mutations, chemo-resistant and high-risk relapse is certain. After chemotherapy, the measurable residual disease positivity was shown of 0.6%. So, bone marrow transplant was done. After transplant, the later MRD showed up 0.16% of MRD, which is least expected in this unfavorable aberrant CD56 expression, which is NK cell marker, and also TP53 mutation, which is high indices for refractory and relapse. These are my references. Thank you.
Thank you very much, Dr. Jayashree, for enlightening us with this information. Has anyone got any questions, please, related to AML or TP53, please? If you have any question, please leave in the chat box. Otherwise, here we are coming to close this